why were you? Besides looking for NCLEX style questions, obviously, is look for practice problems that give you some clinical context, because that is what you're going to actually be dealing with in the real world. You're never like, I know I'm kind of repeating myself here, but you're never going to see an ABG, an arterial blood gas value with no context at all. So look for problems that share with you, not just, okay, here's the pH and here's this and here's that, because you've had practice at that. What you really want to do is when you're hunting for practice problems, look for the ones that give you the clinical picture, because that will really help reinforce for you, oh, when they're breathing like this because of this kind of respiratory problem, that's the pH I can expect to see, or that's the imbalance I can expect to see. Or similarly, if they're drying dehydrated and puking or having diarrhea or whatever, this is what I can expect to see, okay? So that is really my big recommendation for you, is to continue to get comfortable with these, is to look for those problems. There's a ton of them out there that give you that clinical picture, okay? As advertised, I am going to do a quick overview of mechanical ventilation. We talked in the first part of the lecture about lots of different kinds of patients who might be candidates for mechanical ventilation or needing an advanced airway. Now, some of you might see this and go, oh my God, I'm like, what, really? And some of you are like, yes, I really wish that was in the nursing scope of practice to do that. It's not, by the way, just to be clear. Believe me, I've been asked more than once. So, what you're looking at up here, of course, is an endotracheal tube. You can have patients who have an advanced airway who are technically intubated with an oral airway tube that goes or you can have someone who's nasally intubated, but typically this is what you're going to see, particularly in an emergent situation or in an ICU situation. There are other ways to secure an airway that are not going to require mechanical ventilation of some kind like this. Maybe you guys have seen them, maybe not. Has anyone seen, it's like a little curved piece of plastic. It's an oral airway. I don't know if you guys have played around with those here in your skills lab or anything like that. And the other one would be a nasopharyngeal airway, which is a thin plastic tube, which I gotta say, in my med-surg practice days, I most commonly saw used rectally attached to a Foley bag for fecal management, but that's like a whole other story. In this case, we're talking about airway management, okay? And so generally, there are lots and lots of different types of ventilators, and if you do end up going into critical care or sometime down the road into emergency medicine or emergency nursing, you will become at least somewhat familiar with, somewhat to very familiar with what kind of ventilator your institution uses, but they are basically all doing the same thing, which is they set a respiratory rate, they set a volume, so the volume of air and oxygen is being pushed into the lungs. And it will have settings dependent upon whether it's about volume, whether it's about overcoming resistance in the lungs, depending on what's going on with that patient. Like I said at the beginning, I'm not going to get too deep into it. Please don't worry about it. But just to know, when we talk about ventilator settings, that's what we're going to be talking about. Things like positive end airway expiratory pressure, which means you guys know that with the lungs, when you exhale, the lungs don't fully deflate like a shriveled up balloon. You can actually do settings on the ventilator to set exactly how much pressure is keeping the lungs open at the end of expiration. It's really cool. That person's pretty sick if you need to do that, but that is something that's available to you. And some of you will look at mechanical ventilation and be like, Ron, and panic, but don't do that, okay? Because the actual nursing interventions that you can do for these patients are really pretty straightforward, and you'll see at the end sort of my big takeaway for troubleshooting, which is, I'll just go away as much right now, call the respiratory therapist, okay? Because they're the ones typically who are going to be adjusting settings on the ventilator and checking things like that, but there are some easy things that you can do. So, why would somebody need to be intubated? We talked about a few disease states where a patient might run into trouble, and from a respiratory disease state perspective, the one I named was asthma, heart failure, COPD, those kinds of things where you know you have a patient who's having difficulty moving air appropriately, might be a candidate for intubation and mechanical ventilation. But there's kind of two main categories, which are hypoxemic or hypercapnic, which is just a fancy way of too much CO2, of saying too much CO2. The only contraindication, of course, is if you have a patient with a do not intubate order, which may or may not go hand in hand with a DNR order. So again, when you're in clinical practice, you check the bracelet. If your organization has a bracelet, which most people do anymore, check the orders, make sure that you have a clear understanding of what does that patient want if they lose their airway, okay? It's going to be true in whatever clinical setting you practice in. So I just emphasize that to say, make sure you know if that patient does run into trouble. Yes? That side is because every institution has different language that they use to talk about possible extreme intervention options with patients and their family members.
It's okay.
Hard call, D4E, so they know they need to intubate that patient, right? So, I mean, this is happening around us, right? So, trial intubation, my guess, because I'm not familiar with that specific terminology, but my educated guess would be if there is some thought that the patient can be supported with mechanical ventilation for a limited period of time and then be brought back to sort of a well enough state that they no longer require it, that patient has indicated, or that family member, that healthcare proxy has indicated they would be comfortable with a trial of intubation in that sense. If it's this person has severe ARDS, which is okay, and they're looking like they're going to need to be intubated for enough number of days or weeks that you would start to think about whether this patient actually needs a trach for longer term vent care, or whether they're being proned, which again I'm going to call it no.
They don't know that.
No, well, our clinical group does, because I talked about.
Right, but they don't learn that
That's
here.
okay,
Yeah.
that's fine. We'll move on from that. But anyway, where they are in such a severe respiratory compromised state that it is unlikely that they will be able to be successfully weaned off the ventilator, but they don't want that. That's my, again, I'm not familiar with that specific terminology. I worked somewhere once that had DNR options A, B, and C, and it got super confusing for everybody. But really, those things are a way to talk sanely with patients and their families about essentially like somebody who's that ill moving towards end of life care. That's a whole other conversation. If you have a patient with an ET tube, or less commonly they're intubated, you're going to be looking at the position. They're all marked with ruler lines, so you want to know what the distance is of the lip when that patient has been successfully intubated, and the tube is secured in place. In the olden days, it would be secured with some pieces of tape, but think about skin integrity and problems with having to change tape on someone's tracheal tube every day. So most places now will have some kind of less traumatic to the skin securement device for the tube. But anyway, you want to check the position. The cuff inflation, if you saw on that picture, it might be a little hard to see. There's a little, almost like, see that little tiny blue thing up there? That's almost, think of when you inflate a Foley balloon, but you inflate this water rather than water or saline. And it basically, it inflates a balloon here in the airway to hold it in place. So you want to check and make sure that that's inflated securely. Oral cavity. Someone earlier, when we were talking about care of patients with respiratory issues, talked about oral care. That is, I cannot emphasize to you how important that is with a patient who is intubated. Why? What's that? Pneumonia. What's that? Infections. Yes, these patients, they have an invasive tube in their airway. They are at high risk for what's called a ventilator-associated or a ventilator-acquired pneumonia. So most places will have some kind of protocol for either Q-shift or Q4 hour or even work equipment oral care. So there's like a toothette with suction that you can use to clean out their oral cavity really well. That's super duper important. Trauma to the lip and palate, when you're heading to assessment on an intubated patient, you're checking to see if that securement device is causing any pressure injury, or if there was any damage or cuts to the lip on intubation, which if they were intubated emergently in the field, there might have been. So those are the kinds of things that you will be looking for. And then secretion. again, those of you who have maybe seen this or will be in the ICU, you'll see all of the ventilator tubing, and there will also be what's called inline suction, so you can actually suction right down the tube. They know suctioning, maybe? Do you suction on the way in or on the way out?
Way out.
Thank you, okay, just making sure, I'm just making sure, guys. So, same thing goes for ET tube suctioning, okay? So nurses will do that, and you don't hyperoxygenate, they're already on a ventilator, but you want to suction out if they have secretions. Make sure you even suction out the oral cavity really well for the reasons we just talked about, okay? So, that's one aspect of caring for the patient, and you're basically caring for the tube. But the other considerations, the patient position, what position do you think would be optimal, barring any other contraindications for someone who's on a ventilator? 30 degrees or even higher, actually, 45, 40, yeah, 30 to 45, somewhere in there. 30 we talk about with protecting skin integrity and things like that. But if you want them up if you can. Check in your vital signs. You're checking for bilateral breath sounds. Even if you know the tube placement has been confirmed, that should be part of your assessment anyway. But that's something to think about, because if yesterday you heard them both clearly, and today one seems a little diminished or something's not quite right or muffled, what could possibly have happened? The tube can get dislodged, or kind of go down one side to the other. So you want to kind of keep an eye on that. So alarms. And again, when you're the nurse, if you can't sort of immediately troubleshoot a vent alarm, all else fails, you can disconnect the patient from the vent, use an ambu bag. Did you know that? You can take the mask off and attach just the plastic part to the endotracheal tube, and you can bag the patient that way. Yeah. And call the respiratory therapist and get them to help you figure out if there's a leak someplace, if there's a pressure problem. Sometimes patients will, they're usually, I won't say always, but usually on some kind of sedation medication, but they might be biting on the tube, and that can actually cause the vent to alarm. So those are the kinds of things that you're going to be assessing if you have this patient. Understanding the reason for intubation, again, it kind of goes back to, don't just look at what's going on, but think about the why. Why do they need to be, why do they need to have a breathing tube? Why are they on the ventilator? Do they still need to be intubated and mechanically ventilated? That patient who maybe agreed to, well, if I can get a little bit of rest of my work of breathing for a couple of days and then come off the vent, that'd be okay. But what will happen is that they will try to gradually back off on the ventilator doing the work of breathing for the patient, and it's called SPONT trials, which stands for like spontaneous breath. So they'll see, is the patient able to sustain a respiratory rate on his or her own? Is the patient able to breathe a sufficient kind of volume to maintain their O2 sat without getting overly distressed? And if they can, that's a patient we might be able to consider weaning off the vent and then eventually extubating, which is what we want for our patients generally. I'm just going to brag for a minute about a project that's going on at Upstate right now, actually, because the medical ICU has patients who are intubated, sometimes has patients who are intubated, and they're awake. They're not sedated, they're not getting a pain med drip, they are awake, they know what's going on around them, if they haven't sort of started to develop ICU delirium anyway. And that can be incredibly stressful, as you might imagine, to be lying awake in an unfamiliar room with a breathing tube down your throat, which you can't talk, right? So one of the things that one of our medical ICUs is doing right now is trialing touchpad software touchpad software for iPads to communicate more effectively with intubated awake patients. So they can do things like, it hurts here, and like point to a part of the body, or I'm cold, or where's my husband, or whatever. And I think other ways that we've had of communicating with those patients have been imperfect, to say the least. So that's a consideration too, is if that patient is awake and able to communicate, are you doing what you can to make sure that they know what their needs are so that they can meet that to the best of your ability? So that's my little bragging on one of the nurses who did that for their nurse residency project when they were a new nurse, and now they're actually trialing it. So, and then the other thing is for your patients who are asleep, who are on a sedative drip, who are on a pain medicine drip. Oftentimes we will have a protocol written for something called a sedation vacation. Why would you do that? Deliberately turn down or turn off the sedation or the pain med drip. Yes.
To see if they're ready to be extubated.
To see if they're ready to be extubated, possibly. What else? To maybe manage possibility of medication tolerance, that's one possibility. What else? Excuse me. Thank you.
Depending on the situation, maybe to assess the patient, like to do an accurate neuro assessment if they've had a
Yes,
TBI.
absolutely. If they've had a TBI, if they've had a stroke, on our neurointensive care unit, they wake their patients up all the time so they can do an actual, like, accurate neuro assessment, because those subtle changes can, have big meaning. What else? There's one other one that I want you guys to be thinking about if you're thinking about patients who are intubated in the ICU for any real period of time. I hinted at it a few minutes ago. If you're in an unfamiliar environment with lights and alarms, unfamiliar people, ICU delirium. Yes, okay? So patients who are, this is a real risk, we actually have whole checklists for assessing for delirium, not just delirium risk, but actual signs and symptoms of delirium, which is an acute confusion, and can come really, you see your sundowning patients, those of you that see sundowners in the evenings, but with ICU patients, there's something very specific about ICU delirium because it's such a disruptive environment. ICUs have really led the charge of having quiet hours where they try to decrease stimulation, decrease the lights, not just at night, but even for periods during the daytime so their patients can get rest. Yes?
So essentially saying you would reduce their sedation.
To reorient them and to assess for signs and symptoms of delirium. So the way that works in practice, if that seems like what you're asking, is you turn down the meds, you kind of wait for them to kind of wake up, you say, hey, Mrs. So-and-so, I'm Caitlin, I'm your nurse, do you remember where you are, like how are you feeling, like how are you doing? And they may or may not be able to tell you because again, they're intubated, but you can kind of get a sense of if they understand what's going on, and ideally using that touchpad or something similar, writing on a whiteboard might work to kind of assess how their mentation is, and if they understand what's going on with them. And sometimes it's, if it can be done safely, a really great way to talk with that patient about the plan of care. You know, and you can't really do that with somebody who's on a sedative drip. So that's another reason that might be utilized. Other questions about caring for vented patients? As I said, this is an incredibly brief overview. There's a whole other lecture I'm sparing you about vent settings and kind of how to measure those and see what's going on and all of that. But really, as a practical matter, if you're the nurse in the ICU, it is your responsibility to know what those vent settings are and what they mean, and you'll be taught all of that in your hospital's critical care course. And then it's really going to be your job to do all those other assessments and monitoring interventions that I just named. Okay, so that's really your takeaway from here is to think about why is this patient intubated? Can we give them a break from the sedation or a sedation vacation to try to assess their mentation? How are they looking? Are they fighting the ventilator breaths, or are they in sync with the machine? Those are really the kinds of things that you're going to be looking at. And your troubleshooting and emergency management, when in doubt, bag the patient and call the respiratory therapist. Honestly, that's it. Because I think the ventilator can be a little intimidating, but if you go back to your ABCs and something's going on with that machine and you don't know why, you have an airway, so you have that to utilize. And again, if you're working in this environment, you'll have an ambu bag right in the room. So easy peasy, pop off the mask, bag the patient, and then get help, okay? And this, I told you this part would be quick because we have another gate. Yes, ma'am?
How much can you move a patient from a ventilator, like to turn in position?
That's a great question. So did everyone hear that great question? How much can you move a patient who's on a ventilator? And I know why you're asking because it seems like all of that equipment would really kind of get in the way. So patients can go to tests, patients can get transferred to another room if they have to be, usually you don't want them to be. But yes, patients who are ventilated on a ventilator and really unstable, you don't want to be moving them around a lot. But yes, you can turn and reposition them unless they have really good contraindications of why not. They're like really unstable and you can't move them without their pressure dropping in the 30s, you know, that kind of thing. But otherwise, this should not prohibit you from doing good skin care. It shouldn't prohibit you from doing good turning and repositioning, from doing passive range of motion. And those are all nursing interventions that you can do to protect these patients. Then, you know what I mean? There's a The other thing too is worst case scenario, if someone does have to be transported off the unit for something, you'll call the respiratory therapist, disconnect the vet, and they will bag the patient while you walk. So imagine, if you will, a hospital bed, like 2 or 3 nurses, a rescue med box, and a respiratory therapist bagging the patient, and like a partridge in a pear tree. I mean, it's really like quite a production to do, which is why nurses in the ICU typically take care of 1 to 2 patients only, because all of that work to care for that patient, you know what I mean? You can spend all day in one patient's room in those kinds of units. So, but yeah, that's the answer to that question. You can usually do all of that stuff unless there's some other significant contraindication why you can't. In the trauma ICU, if you've got patients with fractures and things like that, then their mobility might be more limited, that kind of thing. If you have a spinal patient, things like that. Other questions? Awesome. Okay, so I should, in full disclosure, I should tell you, lecturing is not normally my preferred mode. There's a lot of you, so having like a big group discussion about the importance of acid-base imbalance would not be very practical. But we can play games, and so we're going to do one more game together as a group. I've designed a Jeopardy style game. So, a couple of things. It only allows me to create up to 4 teams, so that would still be a lot of people. So what I think I'm going to do, now that I think I'm just going to do it, we're all as one team, because I saw how competitive you guys got with this quiz at the beginning. What I really want is for people to think through the answers, which again will be posed in the form of a question, because it's Jeopardy. I'm not Alex Trebek, but that's about it, okay? And this will just kind of bring us home and should help tie together everything else that we have done this evening. And I gotta say, guys, I so appreciate your attention and really just to play along with my games and my goofy slides, and I just really have enjoyed it. So, all about that acid-base imbalance, once again. Your categories are ABG values, balancing act, respiratory, metabolic, compensatory, and ventilators. Given the time, I'm not altogether certain that we will get through all of these, but we will do our best. And at the very least, I want to get at least 2 in each category. I think we could probably do even more than that, okay? Yeah. So, I will pick the first one just for the sake of someone's got to start somewhere. Oh, you want to start? Go for it. Let's hear it. What's that? Ventilators for 500. You are like here. So when I click on this, rather than everyone kind of shout it out if you want to, but I'd love to have someone actually. I don't have buzzers for you. That's the other limitation here. So okay, here we go. Ready, guys? Ventilators for 500. Yes. Which is called? What is a sedation vacation? Good. See, I told you in the form of a question. Just okay. I'm gonna let you pick the next one. Compensatory mechanisms for 500. This is so interesting. Every time I do a Jeopardy game, I'm looking for big money first, and that's so funny. Oh, this I might not have talked about specifically, so this is a good reminder to me that we should cover this real quick. But if I would like to take a guess, think about your metabolic alkalosis patient. Think about how they're breathing, and what possible problem could they run into? What's that? Not exactly. What is hypoxia? Why? If this person is in a metabolic alkalosis state, their pH is what? So what are they trying to do to compensate? They're trying to retain CO2. Can you retain CO2 indefinitely? Can you end up with like 100% CO2? Well, yeah, but then what happens? Yeah, right. So, the risk of hypoxia, hint, the risk of hypoxia is a limiting factor in respiratory compensation for metabolic alkalosis because you are slowly breathing down, you're trying to retain that CO2, but you can't do that indefinitely. Yes.
Can you repeat that last thing?
Yes. The hint. The risk for hypoxia is a limiting factor in the body's ability to compensate for a metabolic alkalosis by way of the respiratory system. Remember, it's a metabolic problem, respiratory system tries to compensate. If respiratory system is trying to compensate by retaining CO2, then what happens? I'm seeing some light bulbs go off. I'm also seeing some question marks over heads. So if I'm not breathing very fast or very deep, I'm not taking in enough O2 because I'm trying to retain CO2, but then I run into this problem, okay? Are we good with that one? Can we go on? Maybe? Maybe. All right. What's that? Yeah, no, she got it. She gets to choose. Metabolic for 500. We're going through the gusto here, guys. An SU track and field athlete comes to you with uncompensated metabolic acidosis. I'm going to pick someone who hasn't answered quite yet because you guys before. Yes. Oh my gosh. Guys, we're listening. I'm so happy. Yes. All right. Did everyone catch that? Yep. Okay. You will not, just as an FYI, it isn't only athletes that can get rhabdo, just to be clear, okay? The little old lady who was found on her floor in her living room for 2 days, that person can also have rhabdo. Why?
She hasn't moved in 2 days.
Because she's not using her muscles, and so they're what? They're breaking down. Yep, absolutely. Okay, so just to be clear on that. That typical like athlete, I think that's the picture that people normally get, but it doesn't always play out that way. All right. Balancing act for 400. I think we just talked about this one a few questions ago. Mr. Retain CO2, compensate, yes. Yep, in the form of a question, I know, right, we're sticklers around here for that, right? So that's the scenario I described just a few minutes ago, okay, good. What's next? Okay. And if I'm going through these too quickly and people want to be taking notes, please just shout out and I'll slow down. Can you post? I can send this game, yeah, absolutely. I'm sorry, what did you want to select? You got it. What's that? Uh-oh. What is 22 to 26? Bonus points if you can remember the unit of measurement.
MML something.
Okay.
Millimoles per
All right,
liter.
who would like to start us off? I'm going to let someone else pick the next category, but you get all the glory for getting the question, okay? Someone else pick the next category. Oh my goodness. Do I have to pick? Seriously? Respiratory for 5. Thank you. There we go. So think about what good. Why? This is a tricky one. What's that? Well, that's carbon monoxide, right? All right, you guys, what's up next? Balancing act for 500. Here we go. If you haven't learned anything else from me tonight, it should be this. What's that? No, for any acid-base imbalance, this must be the priority. Okay, so yes. But what if it's not an airway problem? Say that really loud, please.
Finding the root cause.
Thank you. Including the underlying cause. And I'm so glad actually that someone over here said draw an ADG, because yes, that will give you the information that you need to know to start fixing the underlying cause, but it's kind of like that O2, you bump up the O2 on the nasal cannula, you haven't really fixed the problem. You've helped alleviate the result of the problem, but you haven't quite fixed it, right? So always look at your patient's health history, because you might dig up something that's actually causing them a problem that isn't even why they came to the hospital. That happens a lot, okay? Great. Can you pick the next category for us?
Erin.
Oh, I don't know your name.
Oh,
Who,
sorry.
That's okay.
ABG values for 400.
ABG values for 400. Was that no? I heard it up front here. 35 to 45. Yeah. So, and that's why that can get tricky, because I heard half of it up here. So that can get tricky too. 7.35 to 7.45 is what? Age. So the 35 to 45 is like a quick, like your brain might flip them, but it's like, if you look at it, it's a good way to remember both, okay? So, the right answer is 35 to 45, okay? Good. Who's gonna pick the next category for us? Very good. That's a look. All right, what's the next one? What's that, ventilator for 400? I wanna
Who are respiratory therapists?
yes.
Alex.
This is a good thing to sort of focus on too, because I can tell you in a few months from now, when you guys are all graduated from school, it will happen, I promise. And when you pass your boards, which will also happen, and you're out there working, and you are like, oh my gosh, I'm about to come off orientation and take care of these patients, and OMG, I'm gonna have to do all of this myself. Please, please, please remember that I said this to you. No nurse does it all by themselves. And I have seen this countless times where nurses are like, the only way I'll know I'm being successful as in practice is if I can do it all myself all day long. And like, you work with a team. Respiratory therapists, like, this is their specialty. They do this for a living. You do too, but you tackle different parts of the pie. So just when in doubt, call for help, call for somebody where this is their job, okay? All right, Carol, you wanna pick the next one?
I can't even see the titles. The third column for 300, because I can't even see what it
That
is.
would
Say
be
respiratory?
Very good. The third column for, I'm sorry,
300?
for 300. So this is a two-parter. Someone want to take a swing at it? Okay. So the kidneys, we associate the kidneys with bicarb, but the kidneys also, in there, they do also excrete excess hydrogen ions. So, that's the kidneys. And so, do the kidneys do that fast or slow?
Slow.
Okay, so just keep that in mind. It's not gonna happen right away, okay? But yes, that is correct. Oh, pick one. Metabolic for 100, okay. Sounds good. We haven't tackled those yet. I wanna like see a hand and, all right, you're good.
Metabolic alcohols.
Okay, why?
Because they're vomiting.
Because they're vomiting what?
All that good stuff.
All that good stuff, yes, they are vomiting, and literally vomiting out acid, yes. All right, and so, very good, okay. All right, Abby, you wanna pick the next one?
I guess. Compensatory mechanisms for 100.
Compensatory mechanisms for 100, okay. Someone raise their hand and shout it out. Yes, sure. Yes. Okay. Again, remember in the beginning when in the quiz at the beginning, when it said this organ is responsible for CO2 and this oxygen, and this organ is responsible for bicarb? I hope at the very least by the end of this we know which she's doing which, so this is the end of that, okay? So, very good. Will you pick our next category for us? I actually made this whole game, I'm so excited.
Oh.
So what state is he in? Metabolic alkalosis, yes. Because what are Tums? Yeah. You take it for your GERD, right? You're like, oh, stomach acid, take a little base. Well, that's a lot. This seems far-fetched, but people ingest all sorts of things that throw their acid-base balance and everything else out. Yes. So, I wouldn't be so shocked. Okay? All right. Who's next? Ventilators for 100. Yes, ambu bag. I didn't even talk about this, but I think this is pretty self-explanatory. If your patient has self-extubated, and yes, it happens, I've seen patients pull out their ET tubes. I've seen patients pull out their Foleys with the balloon inflated, which is a whole other conversation. I know, listen.
Maybe you should put it
I
in a permit.
know. Megan's making faces back there, it's great. Yeah, when you see the like tiny little lady with it like hanging down by the leg strap around her leg and the balloon still inflated, that's a bad day. So, but not quite as bad a day as a self-extubated ICU patient. Sometimes these patients will stay extubated. Sometimes you might have a patient who was either on light or no sedation, and this was part of like an accidental trial of extubation, and then they do fine, and then they don't retube them. That's actually like a pretty good outcome. But sometimes that's not the case, and so then yes, you would want to bag the patient until you can get further help, which generally speaking means that someone from the anesthesia service has to come and reintubate the patient. Okay? So, bag valve mask. Very good. What's next? What's that? 400? Okay. Are we all in agreement here? Okay. Okay, so we talked about this one full show. Hello? I'm hearing both respiratory alkalosis and respiratory acidosis. What do we think? Respiratory alkalosis. I don't want to do that. So, why? Defend your answer. Why respiratory alkalosis? Because they're hyperventilating. Okay. So, good. Makes sense. So it's weird because we talk about a lot of different pulmonary disease states where people have labored breathing. So it can be easy to think, oh, well, what about like that CHF patient who's like they're breathing really hard, like are they acidotic, are they alkalotic? Sometimes you won't know until you do the ABG. That's why in that quiz earlier, when I said, you know, could a person with pneumonia be acidotic or alkalotic, and the answer is yes. It just really kind of depends on how well they're ventilating and how much CO2 they're retaining or blowing off, depending upon the respiratory pattern. But yes, that person in acute asthma attack who's like really in significant danger of losing their airway, they are probably alkalotic. Because of the hyperventilation. All right. Who's next? Oh, come on, you guys.
ABG values for 100.
400, the last 400 one, we'll knock that out. Okay.
Yep.
So this is like this is a little bit tricky because you have the hint word up there. But what can happen with CNS respiratory depression? Yep, because why? And so you're not right. So what are the kidneys gonna do to compensate? What do they reabsorb to try to reset the balance? Okay, you guys are getting this. Now we're good. All right. Megan, tell me when you want me to wrap, because we can probably finish this in the next few minutes.
Okay.
Okay. Who wants to pick the next category? Someone who has not picked one yet. Someone who's in there going, I don't know about this. No, you picked plenty. Someone who has not picked one yet.
Join me.
ABG is 300. Very good. I want to hear this as like a chorus. Wonderful. Thank you. Yes, 7.35 to 7.45. Very good. What's next? Someone else who has not called out a category.
Balancing act for 300.
Balancing act for 300.
Yeah, Bear.
What's that?
Compensation.
What is?
Compensation. Yes.
Compensate for metabolic acidosis specifically, right? These patients are deceptively sick. They may be a lot sicker than they look sometimes, which is a good to know. Okay? That was kind of a group effort, so Carol, do you want to take it or somebody else who has not? What's that? All right, and then I'm gonna have someone else pick. Okay. For those of you who like numbers.
20 to 1.
Okay, someone else who's not picked one yet. We're getting there, guys.
Metabolic 300.
What's that? I heard a metabolic for 300. Oh, wait, I did this one already. Sorry, you guys. Hold on. I don't know how that did go away. My apologies. Let's try a different one.
Do the next one for 300.
Perfect.
Yeah.
What's that? 200. 200 then. Okay, good. So, kind of a different twist. Nope. So think about that for just a minute, because I know we had a similar question, but now think about the patient and family teaching aspect. How do you explain that to somebody? You guys have now like spent a couple hours with me learning about how all of this works, more or less. So how do you explain that to a parent who's saying, well, his problem's his sugar. Why is he breathing like that? He's not in pain. I don't think he's in pain. Why is he breathing like that? If I'm the mom, someone tell me how you would explain that to me.
Your lungs are compensating for the disruption.
What do his lungs have to do with diabetes?
Low confidence.
What's that?
CO2 said make it low off.
CO2, but I thought he had a problem with sugar. I mean, I'm sort of being the devil's advocate here, but you gotta think about if you're taking care of this patient and you're trying to explain to either them or their family what's going on and why you're doing the interventions that you're doing or why they are seeing their loved one the way that they are, you know, part of nursing is that patient education piece where you have to describe what they're seeing in a way that they're gonna be able to understand. Does that make sense? Someone wanna have another try at it? I'm the mom, that's my kid in the bed, they're small breathing.
Because the organs work together to try to compensate for the the high glucose in his system by trying to get rid of the CO2. I don't know, but trying to like explain how the organs work together to help bring the body back to homeostasis.
Oh, no. I heard go get the charge nurse. I like that answer. And seriously, like you may fumble, and that's okay. But the idea is that you're helping that person understand that both this is the body's mechanism for helping this person get better, and this is what we're going to do as well. You can talk about ketones, and you can talk about the different medication treatments that you would give, which again is sort of beyond the scope of what we're doing. But for DKA, you're looking at electrolytes, you're looking at insulin, obviously, and actually sort of doing this very funny dance between potassium, glucose, and insulin all together. But you can explain all of that, and then in your actions, you're working to make sure that the interventions that you're doing are helping that patient's symptoms. Does that make sense? Yes. So think that over when you're studying these and think, okay, if this was my patient and their loved one is standing by the bedside going, why does the vent alarm keep going off? Or why are they only breathing every so often? Well, I've been watching and they've only breathed 6 times this minute. Is everything okay? You need to think about not only what could be going on here, but how am I going to describe that to my colleagues, to the provider, and also to the patient and their family. Yes.
So quick question, one of the things that we didn't touch base on is the sweet smell when they're in DKA from their
Yes.
breath.
Yeah.
So that's part of the ketones?
Does anyone experience that before? When you have a patient in diabetic ketoacidosis, their breath smells sweet. It's not the sugar, which is what you would think that it is, but it's actually, it's the ketones. So, but yeah, so you can describe that, because that's a great symptom that someone else can see or smell anyway. All right, we're gonna do, should we finish these out? What do you guys think? Just,
Can you just open them and?
yep, and I can send the link around to you guys can review as well. Okay, this is a gimme, come on guys. Yes, thank you. And, oh, that came out bigger than I expected. But here's the thing. You might look at it and go, because you've practiced on your tic-tac-toe grid, oh, this person's in respiratory acidosis. But any abnormal lab and an ABG will always come back with a critical lab value that's abnormal, needs to be reported ASAP. Usually your facility will have a policy about exactly what that time frame means. Okay? Do you guys know what it is at Joe's? Did you guys know that? I don't know.
What's that? I'm sorry?
Time frame for reporting abnormal or critical lab values.
So critical lab, you guys have had this happen maybe yes, no, whatever? Have you been through this?
Maybe not.
Probably not because they usually need to get someone's license number. So the lab will call and they don't usually tell you what lab it is. They just say you have a critical lab value and then they want to know what your employee ID is. So they want to talk to someone with a license, which is maybe why you haven't been involved yet. And then you have to go to the labs, look it up, and you are supposed to call the provider like then.
Yeah, basically. All right, good. Very good. Okay. Makes sense?
Yeah.
These lower dominant ones are kind of the gimmies. We're gonna do a couple more over here and then good. So you can't just judge what's going on by the pH. That's why you have to look at the whole picture. Okay? We'll finish out compensatory mechanisms. You guys, what have we been talking about? And the only reason I keep harping on that is this is one that people see a lot. Even though that respiratory alkalosis is sort of known as the more common acid-base imbalance, when you have patients in the hospital, generally speaking, they are there with acute issues with a chronic illness, and that disqualifies, okay? I don't know if we specifically talked about this, but see if you can figure it out.
Sedation?
What's that?
Sedation.
Yes, very good, you guys. That doesn't mean snow them until 7 in the morning, which depends who you talk to on nights, but that might be their solution. But if this patient needs to be ventilated, it is better be for a darn good reason. And if they're fighting the vent, meaning they're trying to breathe over and above what the vent is doing for them, or continue to bite down on the tube so that's compromising their airway, that patient might need an anxiolytic, might need a little bit of sedation, not to be snowed, but so that they can actually reduce their work of breathing, which is really the whole point of why they're on the vent in the first place. Ding. Last few. So we talked about this towards the beginning. 80 to 100. Good. Lungs. Good job, you guys. All right, we got 2 more here. CO2. Good. And last but not, and there's no final jeopardy. I'm sorry, that might be a little anticlimactic. I apologize. So this is a nursing intervention. Skin breakdown. Good. Okay. A lot of times what we see in the ICUs, and you can have pressure injuries on the hips, the bony prominences, but a lot of times it's device related. So even the nasal cannula, you can get pressure wounds from that. So those are things to kind of keep an eye on. I will send out the link to this game if that would be helpful. You guys already have the slides. I can send out the little quiz if you think that would be fun, just to practice questions those at home. You can do it as almost like a post-test later and see what you learned after this lecture. And I think we're gonna be about done videotaping me soon. And I will, once I can. And once I have converted that